If you are looking to understand the anatomical structure of the bladder, or you are reading the bladder and you are not getting it, don't scroll, don't leave this channel, because this is the perfect video for you. Because in this video I'll be talking about the gross anatomy of the bladder. I remain your great science tutor Lorenzo, and if you are new to my channel, make sure to subscribe and turn on your post notification button so that anytime I drop any video you'll be sure to be notified. And if you want me to make a video for you, also write it down in the comment section. When I come to it, I will make that video for you. If you have any question, also drop it down in the comment section. So let us jump right into the video. Talking about the bladder, first of all, we're introducing it. So what is the bladder anatomically? Let us take it small. What is the bladder anatomically? The bladder is what we call a muscular reservoir. The bladder is a muscular reservoir of urine. So it holds urine for some time, because when urine is released from the kidney through the ureter, it gets stored in the bladder until you are allowed to release it. Don't forget, it's a muscular reservoir of urine located in the anterior part of the lesser pelvic. So it stores urine for a short time. It's not when it comes from the kidney to the ureter, it stores in the bladder, then you let it out. No, when it comes, it stays for some time until it reaches its capacity before you now release it. And don't forget, it's located in front of the anterior part of the lesser pelvic. The next question we'll ask ourselves, what is the location of the bladder? Where is the bladder located? Because we say it's a muscular reservoir of urine. So take for instance, looking at a bucket or a GP tank, a tank that holds water, that is how the bladder is. But always know it's until it reaches its capacity. So first of all, where is it located? It is located in the lesser pelvis. Located in lesser pelvis, in front of the at the back of the pubic symphysis. Located in the lesser pelvic, at the back of the pubic symphysis. Don't forget it. And again, if it's located at the back of pubic symphysis, what is at the back of it? What is at the back of it? At the back in male, it is the rectum. At the back in male is the rectum. Now for female, you can see the uterus and the vagina. That is what is located at the back of the bladder. Now one thing you have to know, naturally it depends on the capacity and the size of the bladder. So the bladder is not entirely a pelvic organ. It depends. When empty, it is in the pelvic. But when distended, it rises up to the abdomen, to the abdominal cavity rather. So it depends on the capacity of the bladder that we give it, whether it will be a pelvic organ or an abdominal. But it's just when it's empty, it's located in the pelvis. But when it is full, or distended, it rises up to the abdominal cavity. But one thing you have to know, for children, especially lesser than 6 years old, is the bladder is located in the abdominal cavity. But above 6 years old or 7, 8 years old, the bladder begins to descend and become a pelvic organ. Don't forget, depending on the capacity, whether empty or distended. That is why you know the position of the bladder. But naturally, the bladder, when empty, is located in the pelvis, and when full, it rises up to the abdominal cavity, except from children below 6 years old. For the capacity of the bladder, how much urine can the bladder hold? The bladder can hold with a range of 120 to 320 ml, 120 to 320 ml per a duration. 120 to 320 ml. But above 120 320 ml, too many things happen. But the average it can hold is about 320. So at 320, that is the limit averagely a bladder can hold. 120 to 320 with an average of 220. Don't forget. But when it reaches 500 ml, the detrusor, which is the muscle in the bladder, begins to stretch. When it reaches 500 ml. When it reaches 500 ml, and when it starts reaching up to 800 ml, you cannot hold the content of the bladder again. Automatically it will start dropping above 500. So the range is between 120 to 320 with an average of 220. Then above 500 you start feeling pain because the muscles of the bladder will begin to stretch. Then above 800 ml, what happens? It will come outside automatically. Don't forget it. Now with the shape of the bladder is tetrahedral. The bladder is tetrahedral when it is empty. It's just having that four-sided shape, tetrahedral shape. But when it is full, it is oval. Don't forget, tetrahedral when empty, full, oval. Don't forget. So next we'll be talking about is the external features and relation of the bladder. The external features and relation of the bladder. The external features is different parts of the bladder, and the relation is what organs that is related to the bladder, and the peritoneal, both the peritoneal relation and the visceral relation of the bladder. I'll be talking about everything. Judging by the external features, we'll be talking about one. We have the apex of the bladder, we have the base of the bladder, we have the neck of the bladder, and we have the surface of the bladder. The surface of the bladder is we have the superior surface and the inferior-lateral surface. So picking out the first one, very easy. We're talking about the apex of the bladder. The apex of the bladder is a pointy part of the bladder, and that pointy part is connected to the umbilicus by a medial umbilical ligament, by a medial umbilical ligament, which is a remnant of a urachus or allantois. So in utero, when a child is in the womb, you should always know that the bladder is usually connected to the umbilicus, whereby the fetus excretes waste or urine from the bladder directly to the placenta. So it is connected directly, but after the placenta has been cut and clipped, what happens? That connection of the bladder to the umbilicus becomes fibrotic, and when it becomes fibrotic, it forms what we call a median umbilical ligament, which is a true ligament. So that is the apex of the bladder, connected by a median umbilical ligament, a remnant of a urachus or allantois. In front of the umbilicus, what will you see? In front of the apex, you'll be seeing what we call, it is related to the pubic symphysis. It's related to the pubic symphysis and the puboprostatic ligament. The pubic symphysis and the puboprostatic ligament. That's what you see close to the apex of the bladder. For the base of the bladder, is a triangular part. And it is related to what we call the rectum. The rectum is related to the rectum for everybody. So one thing you have to know, that the rectum is in the back of the bladder, especially the base of the bladder. But in male, the upper to third part of the bladder is peritoneum. It is covered by peritoneum. For male, it is called the rectovesical pouch. While for the female, because in the female, what happens? You see the supravaginal part of the cervix there. The supravaginal part of the cervix. So it is covered by what we call the uterovesical pouch of Douglas for female. While for male, it is the rectovesical pouch. What is the pouch containing? The pouch is containing, for the female, the pouch is containing the uterus of the bladder. Why for male, it is containing the sigmoid colon and the coil of the intestine. Now for male, I say for the both parties, the upper to third is related to the uterovesical pouch and the rectovesical pouch. Now the lower one third for male is containing what we call the seminal vesicle, the prostate gland, and the vas deferens. The lower one third, is not covered by peritoneum, only the upper to third. Why for female, it is just related to the vagina. Don't forget. Upper to third for male is the rectovesical pouch. Lower one third is containing the prostate, the seminal vesicle, and the vas deferens. For female, the upper to third contains the uterovesical pouch of Douglas, while the lower one third is just a tunnel that separates, called the vagina, that separates the base of the bladder and the rectum. And always know that the front of the rectum, the anterior part of the rectum, is covered by a fascia called the fascia of the novella. So moving on to the neck. The neck is the most fixed part of the bladder. It's very fixed. So during movements, no matter how other part of the bladder will be moving, the neck of the bladder will be fixed. It will not move. So the neck of the bladder is just that transmission part where the bladder empties content to the urethra at the neck. So the neck is the most fixed part. So the neck of the bladder is resting on the prostate in male. While for female, the neck of the bladder is resting on where? It's resting on the urogenital diaphragm. Don't forget. And so many things are related to the neck of the bladder, which we'll be discussing in the later part of the video. So one thing you also know, the surfaces now, we have the superior surface and we have the infero-lateral surface. The superior surface is the part of the bladder that is also covered with peritoneum. So if they ask you now, which part of the bladder is covered by peritoneum? The superior surface and the base, the upper to third of the base. The superior surface entirely is covered by peritoneum, and the posterior one to third, the posterior to third or the base of the bladder is also covered by peritoneum. And what does the peritoneum contain? The coil of the intestine and the sigmoid colon. While for female, also you have the coil of the intestine and the sigmoid colon and also the uterus. Don't forget it. That's the superior surface. And also the inferior-lateral surface, on the other hand, too, the inferior-lateral surface is formed by the downward the descending of the lateral surface of the bladder and the posterior surface. So the two lateral surface of the bladder and the posterior surface meet at the neck of the bladder. They all meet downward at the neck. So the inferior-lateral surface, now, what is it related to? It's related to what we call the PRP, and we have PRP and also OR. PRP and what? OR. What is PRP? We have the puboprostatic ligament, we have the pubic symphysis, and we have the what? Rectopubic space. These are parts related to the inferior lateral surface of the bladder. In front of the inferior-lateral surface, you have the PRP, puboprostatic ligament for male, puboprostatic ligament, rectopubic space, and the pubic symphysis. While the posterior one-third, the posterior part, because in front and in back, the posterior part of the inferior-lateral surface is related to the obturator internus and the levator ani. So the levator ani is part of the muscle of the pelvic floor muscle. It's part of the pelvic floor muscle. The levator ani is part of the pelvic floor muscle. So don't forget. So we have talked about all the external features and their relation of the bladder. Next we'll be moving to is the ligament of the bladder. So the ligament of the bladder. So we have some parts. We have a true ligament and we have a false ligament. So write this down. We have a true ligament and we have a false ligament. Now, the true ligament is which ligament? The true ligament, we have up to four part of the ligament, four true ligament. You have the median umbilical ligament, which I told you from the beginning, is attaching the apex of the bladder to the umbilicus, which I told you is the remnant of the urachus or the allantois. So the next one we have is we have the posterior ligament of the bladder. The posterior ligament of the bladder is attaching the posterior part, which is the base of the bladder, to the lateral pelvic wall. Don't forget, that is the posterior ligament of the bladder. Then that is the second one. We also have what we call the lateral ligament. The lateral ligament in another part is connecting the inferior-lateral surface. Don't forget, write it down. The lateral ligament is connecting the inferior-lateral surface to the tendinous arch of the pelvic fascia. It's connecting the inferior-lateral surface of the bladder to the tendinous arch of the pelvic fascia. So this is the third one. Why the last but not the least is what we call the puboprostatic ligament. The puboprostatic ligament. The puboprostatic ligament is it holds the neck of the bladder in place. It holds the neck of the bladder in place. So you have two puboprostatic ligaments. We have the median puboprostatic and we have the lateral puboprostatic ligament. So don't forget it. All these ligaments fixes the bladder at every different sides. So you can also look at it in your atlas so you can appreciate it more. So write it down. 4 ligaments. You have the median umbilical ligament. We have the posterior ligament of the bladder, we have the lateral ligament of the bladder, and we have the puboprostatic ligament. Now we have false ligament. The false ligament, they are not true ligaments. They are just folds of peritoneum. They are just folds of peritoneum. So the first folds of peritoneum we have is anteriorly. We have the median umbilical fold. So it's a fold of peritoneum around the median umbilical ligament. Around the median umbilical ligament. It's just a fold of peritoneum. So now we have the posterior peritoneal folds of the bladder. The same thing is also connecting, it's also covering the posterior ligament at the back of the bladder. Don't forget. The same way we have the true ligament, we have the false ligament. But the difference between the true and false ligament is that the true ligament are true ligament. They are holding the bladder. If not, they're what we call vesicocele. Vesicocele is a structural issue when the ligament of the bladder are too lax and the bladder begins to descend from the vaginal opening. So it's more common in women than in men. So vesicocele will happen when the two ligaments are laxy and they are not tense and too strong. Vesicocele will occur. So now we are talking about the two ligaments. In the first ligament, the difference between is that the ligament for the first one is fibrous and thick, while the first ligament are just peritoneal folds. And the same name, medial umbilical fold, posterior umbilical folds. Then you now have what we call the lateral folds of the bladder. Lateral folds of the bladder. Now that lateral folds are just covering what we call the umbilical arteries. So don't forget it. So it's very, very easy. all welfare talk about in the ligament. Now we have true and false ligament. We talk about the external features and the relation, which you know. And now the next thing we are going to, the next one we are going into is what we call the inferior surface of the bladder. We are going to the inferior surface of the bladder. Now one thing you have to know now, that when the bladder is empty, the mucosa part of the bladder begins to form what we call a rough appearance. The mucosa wall begins to form a rough appearance called a rug-like appearance, just like a rough rug, just a rug-like appearance. Same with all GIT organ. When there's no food in all the GIT organ, they become rough. Their mucous layer begins to bulge out. But when there's a stimulation that food is coming, what happens? Or urine is coming, what happens? They become smooth. They become smooth. So how will you know now the bladder is smooth? You will see what we call the trigone. There's what we call the trigone vesicae, which is the trigone of the bladder. Don't forget, when the bladder is smooth and you can appreciate the transitional epithelium there, you will see what we call a trigone. We call it the trigone vesicae. The trigone vesicae is the triangular space in the bladder that is connecting the entrance of the entrance orifice, which is the ureteric orifice, and the exit of the bladder, which is the ureteric or what orifice. So they form a triangle called the trigone of the bladder. The first two orifices you see, the ureteric orifice. So we have two ureteric orifices where urine comes from the ureter into the what? Bladder. So you are calling the ureteric orifice. So now the ureteric orifice is joined by what we call the interureteric orifice of what? Mensa. The interureteric orifice of what? Mensa. Now from the two interureteric orifice of Mensa, the two ureteric orifice empties into in the ureteric orifice. So the entrance is the ureteric orifice and the exit is the ureteric orifice. Now I told you that the bar of Mensa, or we call it the Mensa's bar or the bar of Mensa, connects the line connecting the two ureteric orifice, while the interureteric line is connecting the ureteric orifice with the ureteric orifice. So you can call it or ureto-ureteric orifice or ureto-ureteric line of bar. Ureto-ureteric line of what? Bar. So we have the first one, interureteric orifice or interureteric line rather, and you have the one connecting the ureter to the ureteric orifice is called the what? Interureto-ureteric line, or we call it bell bar, The line joining the ureter orifice to the urethra orifice is called the what? Bell's bar. It's called the what? Bell's bar. Now moving on now in that ureteric orifice, in that downside where the urine leaves, there's also a mucosa elevation. That mucosa elevation is very, very important because it marks the point for what we call the prosthetic what? Ureter. It marks the point of the prosthetic ureter. Now that elevation, that mucosa elevation at the what? The ureteric orifice is called the what? Uvular vesicae. The uvular vesicae. Don't forget the uvular what? Vesicae. So the elevation at that interureteric, at that ureteric orifice is called the uvular vesicae. And from the uvular vesicae to the upper part of the what? Seminal colliculus in the ureter, in the first part of the ureter, is called the what? Preprostatic what? Ureter, which we'll talk about in the ureter video. So don't forget it now. So we have the two lines joining the ureteric orifice called the interureteric line of Mensa or the Mensa's bar, and you have the second one, which is the line joining the ureteric orifice to the ureteric orifice. The line is called the Bell bar. Don't forget it. And there's an elevation in the ureteric orifice called the what? Uvular vesicae. Don't forget it. Now moving on to this one, now we have talked about the trigone of the bladder. The next thing we're talking about is the blood supply to the bladder. The blood supply to the bladder. So now in the arterial supply to the bladder, why? Now we have two chief blood supply, which you call it the superior and the inferior what? Vesical artery. The inferior and the superior and the inferior vesical artery. Take a note on it. The superior and the inferior vesical what? Arteries. Why? You also have accessory blood supply, accessory arteries that are also supplying, because most of it cross through the bladder, most of it pass through the bladder and also innervate the bladder. For female, you have the uterine artery and you have the vaginal artery. So the uterine artery and the vaginal artery. For both male and female, you also have an accessory other artery called the obturator artery. So the obturator artery also assists in supplying it too. Now the venous drainage in the on the bladder, where the blood from the bladder drains to. Now always know, for male it is draining to the what we call the prostatic venous plexus, or entirely it is draining in what we call the internal iliac vein, or the prostatic venous plexus. Don't forget it. Now also in the female too, it all can also drain in the plexus located in the broad ligament. So there's a plexus, the uterine plexus, present at the back of the broad ligament. So you see the plexus in the broad ligament. For the female, the blood can also be drained in that part also. For male, the prostatic venous plexus. For female, is the uterine venous plexus in the broad ligament. And entirely they all drain into the internal iliac vein. The next one now is the nerve supply. Very, very important, the nerve supply. So now this is one thing I want you to take note of in the nerve supply. For the nerve supply, very, very important. The nerve here is now naturally the bladder can be controlled autonomically. But urination can be controlled voluntarily. The bladder can be controlled autonomically by the feeling and the urination, but now there's a voluntary part where you feel the urge to urinate and you urinate. Don't forget it. Now in autonomically, it can be innervated by sympathetic and parasympathetic. The sympathetic innervation to the bladder is very simple. It is from T11 to about L2, part of the sympathetic fibers of the spinal cord. T11 to L2, which is the sympathetic fibers from the spinal cord. Don't forget. And what is it doing? It is supplying more. It is motor, and it supply more of the smooth muscles around the internal ureter sphincter. The internal ureter sphincter. So it's motor to the internal ureter sphincter. Where is the internal ureter sphincter? The internal ureter sphincter is located at the neck of the bladder. So it is controlled sympathetically. Now, so which means anything now during filling of the bladder, what happens? The detrusor muscle is the muscles around the bladder. Take note of that. The detrusor muscle is the smooth muscles around the bladder. So during urination, during bladder filling, when urine is coming from the kidney to the ureter, it enters into the ureteric orifice of the bladder, into the bladder, and during that time the detrusor muscle is relaxing. So the detrusor muscle relaxes for urine to enter into the bladder during bladder filling. And at this same part, the sympathetic nervous system stimulates the neck of the bladder to be closed by the internal ureter sphincter. So it stimulates the internal ureter sphincter to be closed during this process. Why the parasympathetic nervous system is innervating the detrusor muscle. It is innervating the detrusor muscle, or it is motor to the detrusor muscle. So now you have to know, during filling of the bladder, what happens? Now the sympathetic nervous system is stimulated to close the neck of the bladder at the internal ureter sphincter, while inhibiting the detrusor muscle to make it relax. So at this particular point, the stimulus is on the sympathetic, while the inhibition is in the detrusor muscle. Don't forget. Why the parasympathetic, during urination, what happens? The detrusor muscle is stimulated to contract while inhibiting the internal ureter sphincter. Don't forget it. So the parasympathetic nervous system, the fiber stimulates the detrusor muscle to the pelvic splanchnic nerve, to the pelvic splanchnic nerve, S2 to S4, pelvic splanchnic nerve. We call it the spinal micturition center. Center. So at this particular point, the detrusor muscle is stimulated when it has gone above the capacity of urination. But you can still control it. How can you control it? You can still control it because in the membranous part of the ureter, there's also a urogenital diaphragm there, which contains skeletal muscle, which makes you control your urination. Don't forget, there's a skeletal muscle there which is supplied by what we call the pudendal nerve. So the pudendal nerve supplies that membranous ureter, which makes us to urinate or not to urinate. Don't forget. So we have to can be controlled somatically through the pudendal nerve, and autonomically by the sympathetic and parasympathetic. The sympathetic is motor to the internal ureter sphincter. The sympathetic is motor to the internal ureter sphincter, while the parasympathetic is motor to the detrusor muscle. So both of them cannot occur at the same time. One will occur. If feeling is occurring, you will stimulate the sympathetic, while if urination is occurring, we stimulate the what? The parasympathetic. And when we want to release the urine voluntarily, we stimulate the what? Pudendal nerve. I hope you understand it. So I took time explaining this part because it is very, very important, especially in your exams. Because in our physiology video, we'll be talking about also micturition in the water, in the renal physiology. So you go check that video up too. Now the lymphatic drainage, the lymphatic drainage of the bladder is what we call the external iliac lymph nodes. Is majorly the external iliac lymph nodes or the internal iliac lymph nodes. Next we'll be talking about here is the clinical correlation, the clinical relevance, or the applied anatomy of the bladder. So what disease can occur in the bladder? What are the structural deformity that occurs in the bladder? Now the first thing we're talking about is the trabeculated bladder. When is the bladder become trabeculated, or the inner mucosal wall become trabeculated? Now anytime there is urinary continence, when there's high amount of urine in the bladder, maybe due to the enlargement of the prostate or due to the obstruction of the ureter, what happens? The bladder will become big. When it becomes big, the muscular wall of the bladder will begins to increase in size, and the bladder will be what we call hypertrophic. Don't forget, the wall of the bladder will become hypertrophic, with the muscle fascicula of the bladder will begin to increase in size due to the increase in urine, and it is caused urine obstruction. So the bladder will now form a trabeculated wave, forming what we call a trabeculated bladder. So it will forming a trabeculated wave due to the enormous amount of urine and the increase in size of the bladder. Don't forget, trabeculated bladder. The next one we'll be talking about is another clinical, so is what we call the suprapubic colostomy. The suprapubic colostomy is a clinical procedure, or we can call it the extraperitoneal procedure of the bladder. So it's just an approach to the bladder into the anterior wall, to the anterior abdominal wall, without getting in contact with the peritoneal cavity. So in this way, we don't want to get in contact with the peritoneal cavity, so we'll go towards the lower part of the anterior abdominal wall, so to approach the bladder. It's just during this particular point when the bladder is distended above a particular capacity and urination is not occurring due to also either enlargement of the prostate or striation or any blockage to the ureter. What happens? We can drain the bladder, or also kidney stones can be removed from the bladder using suprapubic colostomy. Another way again, we can also use it to we can also approach the prostate using suprapubic approach too. So all these ways we can use it to approach the bladder. So sometimes if you just want to drain the bladder or to remove anything from the bladder, we do it suprapubically. Next part, another clinical applied anatomy to the bladder again is what we call the neurogenic bladder. So when you damage the neuronal connection of the brain to the bladder, what happens? Or you damage the spinal micturition center, which is S2 to S4, what happens? Anything, you have what we call neurogenic bladder. Because naturally from the brain, the upper motor neuron, which is the corticospinal tract, carry information from the brain to the muscular wall of our peripheral body, which contains the bladder also. So when there is damage to that neuronal connection, we call it neurogenic bladder. So now when there is a damage to the upper motor neuron above the micturition center, you call it automatic bladder. Automatic bladder. When the corticospinal tract or the upper motor neuron tract is there's a lesion there, or there's a transection of the spinal cord affecting that part, you have automatic bladder, what you call urinary incontinence, where you be urinating and the bladder usually empty 1 to 4 hours. So it's just immediately it is coming, the detrusor muscle will contract reflexly and the urination will just occur. So now it will just be like just like a baby, a newborn baby that have what we call primitive reflex. The next one, but if you now damage if you now damage the pelvic splanchnic nerve, which is the spinal micturition center, S2 to S4, you have what we call autonomous bladder. At this particular point, the bladder will just enlarge. You have what you call urinary continence, and from urinary continence you will be having what? Dripping. Urine will be dripping out because you will not know how to urinate, because at this particular point there is what the parasympathetic nervous system is already inhibited, increasing what we call the sympathetic flow. So the sympathetic nervous system will be stimulating the internal ureter sphincter towards close the bladder continuously, while there's a lesion to the parasympathetic part. So at this particular point, what will happen? You will not be able to control your urination, but the urine will just be dripping through the small holes of the internal ureter sphincter. So don't forget. So I hope it all makes sense, and if you feel that the video is fast, you can also use the auto subtitle from YouTube, or you slow the video down. All we just do so that at least you can understand, and also the video will not take time. That's why it is more or less fast, and I'm just giving you an overview of the anatomy of the word bladder. So if we have talked about the bladder starting from the introduction, which is a muscular reservoir. We talked about the location. It's located at the back of the pubic symphysis, in front of the rectum in male and the uterus in female. We talked about the capacity of the bladder, 120 to 320, with an average of 220. We have talked about the external features of the bladder, which is you have an apex connected to the median umbilical ligament. We have the base, which is related to the rectum and the uterus in female. We also have the neck, which is the fixed part of the bladder, resting on the prostate in male and the urogenital diaphragm in female. So we have talked about all this part. We have talked about the trigone of the bladder. We talked about the blood supply, the nerve supply, and the lymphatic drainage. So I hope you understood it. I hope you understood it. If you don't understand, also go down the comment section and write the part you don't understand, so that also I will give a video to explain it more. If you are just newly joining our video, make sure to subscribe and turn on the notification button, so anytime I drop any video, you'll be sure to be notified. So now we are done with the anatomy of the bladder. So we'll be moving on to the anatomy of the urethra, because we have talked about the anatomy of the urethra. We're talking about the anatomy of the bladder. So we'll be moving next to the anatomy of the urethra. So bye bye.